Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 272 of our pharmacotherapy series, which majors in TB in human immunodeficiency virus infection. The first question reads, FGR is a 32-year-old man who presents to the emergency department complaining of mild pleuritic chest pain and a productive cough. He also has experienced weight loss, fatigue, and night sweats for the past 3 weeks. On questioning, FGR states that he is bisexual and frequently engages in unprotected sex. Chest radiography reveals bilateral interstitial infiltrates. Sputum samples are ordered, and the workup includes acid-fast bacillus smear and culture. A PPD skin test is placed, and an HIV test is ordered. The results of the acid-fast bacillus smear and HIV test are positive, and the induration from the PPD is 6 mm. A CD4+ count is ordered, which is 150 cells per microliter. What are the clinical manifestations of active TB in patients infected with HIV? How effective is skin testing in the diagnosis of TB infection in patients infected with HIV? What diagnostic tests should be performed in FTR? HIV infection is an important risk factor for active TB disease because HIV infects and destroys CD4+ cells, leading to impaired cell-mediated immunity. The immunodeficiency allows for rapid development of active TB disease in a person who is infected with Mycobacterium tuberculosis. TB is a common opportunistic infection in persons infected with HIV, but unlike other opportunistic infections in this population, CD4+ cell count is not a reliable predictor for risk for TB disease. Active TB disease can occur at any CD4+ cell count, but the risk increases as a patient's immunodeficiency progresses. Common symptoms of active disease, such as productive cough, fever, sweats, weight loss, and fatigue, may be present in HIV-infected individuals, but the clinical manifestations of TB depend on the severity of the immunodeficiency at the time of presentation. TB in an HIV-infected person will clinically resemble TB in an HIV-uninfected person if the immunodeficiency is less severe, that is CD4+ count below 350 cells per microliter. The disease will primarily be limited to the lungs in these patients, and upper lobe involvement with or without cavitation will be seen on chest radiography. However, the findings on chest radiography are markedly different in patients with advanced HIV disease. Lower lobe, middle lobe, interstitial, and miliary infiltrates are common, whereas cavitation is seen infrequently. In these patients, TB may be difficult to distinguish from other HIV-related pulmonary opportunistic infections, such as Pneumocystis jirovecii, or Mycobacterium avium complex, and TB should be ruled out in any HIV-infected patient with pulmonary symptoms. Patients with advanced HIV disease may also have normal chest radiographs but still have positive sputum smears for acid-fast bacillus and positive cultures for Mycobacterium tuberculosis. Therefore, a normal chest radiograph does not exclude the possibility of active TB disease. Extrapulmonary TB is more common in HIV-infected persons with CD4+ counts less than 200 cells per microliter. Because of FGR's clinical presentation and positive HIV test, a high index of suspicion and diagnostic workup for active TB are appropriate. A PPD skin test should be placed on HIV-infected patients with suspected TB infection, but sensitivity and specificity of skin testing are poor in patients with HIV infection. Only about 30% to 50% of patients with AIDS and TB will respond to a PPD skin test with an induration greater than 10 mm. Therefore, an induration of 5 mm or more is considered to be a positive reaction in this population. FTR's reaction of 6 mm to the tuberculin skin test should be considered positive. Theoretically, the sensitivity and specificity of interferon gamma release assays are also limited in patients with HIV infection because the tests depend on adequately functioning CD4+ cells. In a study of 294 HIV-infected subjects, indeterminate results were more likely to occur in subjects with a CD4+ count less than 100 cells per microliter compared with those with a CD4+ count of 100 cells per microliter or more. Additional studies found only 64% sensitivity for detection of active TB disease, and false negative results occurred in approximately 25% of HIV-infected patients with documented pulmonary TB. These studies suggest that interferon gamma release assays should not be used alone to exclude active TB in this population. The diagnostic workup for HIV-infected persons is similar to that for HIV-uninfected persons. Chest radiography and sputum samples for acid-fast bacillus smear and culture of 3 sputum specimens should be obtained. Nucleic acid amplification tests can be used to assist in evaluation of HIV-infected persons with positive acid-fast bacillus smears, and a positive nucleic acid amplification result in a patient who is acid-fast bacillus smear positive likely represents active TB. Drug susceptibility testing for all first-line agents should be performed on the initial isolate for all patients, and testing should be repeated if sputum cultures remain positive after 4 months of treatment or become positive after at least 1 month of negative cultures. Susceptibility testing of second-line agents should be limited to specimens from patients who have received prior therapy, or contacts of persons with drug-resistant TB disease, have demonstrated resistance to rifampin or other first-line agents, have positive cultures after 3 months of therapy, or are from regions with a high prevalence of MDR-TB or XDR-TB. Molecular drug resistance tests may also be used to yield faster results. Patients with symptoms of extrapulmonary TB should undergo needle aspiration or tissue biopsy of skin lesions, lymph nodes, or pericardial or pleural fluid, and blood cultures for acid-fast bacillus should be obtained. The next question reads, what is the preferred treatment regimen for TB in FTR? Given his symptoms and positive acid-fast bacillus smear, FTR should be started on multiple drug therapy for treatment of active TB disease. DOT is recommended for all patients with HIV-related TB. FTR's treatment plan should be based on completion of the total number of doses ingested rather than the duration of therapy. Principles and recommendations for treatment of TB in HIV-infected adults are similar to those for HIV-uninfected adults, with a notable exception. The initial 8-week treatment phase in FTR should include isoniazid, rifampin or rifabutin, pyrazinamide, and ethambutol administered daily by DOT, 7 days per week for 56 doses or 5 days per week for 40 doses. However, twice or thrice weekly dosing regimens during the intensive phase have been associated with increased risk of treatment failure or relapse with acquired rifamycin resistance. Therefore, intermittent dosing regimens are no longer recommended during the intensive phase. FTR should also receive supplemental pyridoxine. After the initial phase, if no drug resistance is evident on susceptibility or molecular testing, FTR can be treated with isoniazid and rifampin or rifabutin daily or 2 to 3 times a week by DOT for a minimum of 26 weeks. Although not applicable to FTR because his CD4+ cell count is 150 cells per microliter, it should be noted that twice-weekly continuation therapy with isoniazid and rifampin or isoniazid and rifabutin is not recommended for HIV-infected patients with a CD4+ count less than 100 cells per microliter because of an increased frequency of acquired rifamycin resistance. Twice-weekly administration in the continuation phase may be considered in FTR because his CD4+ count is greater than 100 cells per microliter, but the data supporting this recommendation are limited. In addition, the once-weekly continuation regimen of isoniazid and rifampin is contraindicated in HIV-infected patients because of a high rate of relapse with organisms that have acquired resistance to the rifamycins. A randomized clinical study evaluated the efficacy of 6 months and 9 months of fully intermittent therapy in HIV-infected patients with TB. All patients received 2 months of isoniazid, rifampin, pyrazinamide, and ethambutol, and then patients were randomly assigned to receive either 4 months n equals 167 or 7 months n equals 160 of isoniazid and rifampin. Throughout the study duration, doses were administered thrice weekly. The median viral load was 155,000 copies per milliliter, and the median CD4+ cell count was 160 cells per microliter. Favorable clinical response was similar between the two groups. However, bacteriologic recurrence occurred significantly less frequently in the 9-month group compared with the 6-month group, 7% versus 15% with a p-value less than 0.05. These data may provide support for 9 months of therapy if a fully intermittent regimen is prescribed for TB therapy in HIV-infected patients. The next question reads, how should TB therapy be monitored in FTR? If FTR had cavitary disease on chest radiography or if cultures are positive after 2 months of therapy, treatment with isoniazid and rifampin or rifabutin should be continued to complete a total of 9 months of therapy. If FTR was suspected of having extrapulmonary disease caused by drug-susceptible strains, the recommended treatment is isoniazid, rifampin, pyrazinamide, and ethambutol for 2 months followed by isoniazid and rifampin for 4 to 7 months. However, longer durations of therapy are recommended for extrapulmonary TB involving the CNS, that is meningitis or tuberculoma, or bone and joints. For these infections, many experts recommend 9 to 12 months of therapy. Baseline and monthly evaluations of hepatic function, renal function, complete blood count, and CD4+ cell count are recommended in all HIV-infected patients with active TB disease. In the absence of symptoms, elevations of AST 3 times the upper limit of normal in a patient with symptoms, more than 5 times the upper limit of normal regardless of symptoms, or if a significant increase in alkaline phosphatase and/or bilirubin occurs, hepatotoxic drugs should be stopped and the patient evaluated. For pulmonary TB, at least one sputum specimen should be obtained monthly for acid-fast bacillus smear and culture until 2 consecutive specimens are culture negative. If the acid-fast bacillus smear is positive at the initiation of treatment, acid-fast bacillus smears may be obtained every 2 weeks to provide an early assessment of bacteriologic response to therapy. Results of sputum samples obtained after the initial 8-week treatment phase are important because determination of the duration of the continuation phase will be based on these results. Susceptibility testing should be performed on all isolates, and susceptibility testing should be repeated on a newly obtained sputum sample if cultures are positive for Mycobacterium tuberculosis after 3 months of therapy. Patients with positive cultures at or after 4 months of therapy should be considered treatment failures. At every visit, patients should be questioned about adherence to therapy and possible adverse events to the treatment regimen. If a patient is experiencing adverse events, the first-line drugs should not be discontinued permanently without strong evidence that a specific agent is the cause of the adverse event. Drug concentration monitoring may be useful to help guide therapy in patients who respond slowly to the prescribed treatment regimen. The next question reads, when should antiretroviral therapy, abbreviated as ART, be initiated in FTR? Optimal management of active TB disease in patients infected with HIV requires treatment of both infections. Sequential treatment of TB followed by treatment of HIV is not recommended. In patients with HIV infection, CD4+ cells multiply in response to Mycobacterium tuberculosis, and then HIV replication accelerates within the lymphocytes and macrophages, which leads to progression of HIV disease. Therefore, initiation of antiretroviral therapy can prevent progression of HIV disease and reduce morbidity and mortality associated with TB and other opportunistic infections. However, this approach may be associated with cumulative drug toxicities, significant drug interactions, a higher pill burden, and the potential for development of immune reconstitution inflammatory syndrome, abbreviated as IRIS. 3 studies addressed the optimal timing to initiate antiretroviral therapy during the treatment of active TB disease. In antiretroviral therapy-naive patients, antiretroviral therapy should be initiated within 2 weeks of starting TB therapy in patients with a CD4+ count less than 50 cells per microliter. Early initiation of antiretroviral therapy significantly reduces mortality in these patients, but the risk of IRIS is increased. In patients with CD4+ counts of 50 cells per microliter or greater who present with severe TB disease, that is low Karnofsky score, low body mass index, low hemoglobin, low albumin, organ system dysfunction, or extensive disease, antiretroviral therapy should be initiated within 2 to 4 weeks of starting TB therapy. In patients with CD4+ counts of 50 cells per microliter or greater who do not have severe TB disease, ART should be initiated within 8 to 12 weeks of initiating TB therapy. If IRIS develops, neither therapy for TB nor HIV should be discontinued. Because FGR is antiretroviral therapy naive and his CD4+ count is 150 cells per microliter, antiretroviral therapy should be initiated within 8 to 12 weeks of starting treatment for active TB. If FGR was receiving antiretroviral therapy when diagnosed with TB, treatment for TB should be started immediately, and antiretroviral therapy should be modified to maintain virologic suppression while reducing the risk for drug-drug interactions. Antiretroviral therapy should not be withheld simply because the patient is being treated for TB, and erythromycin should not be excluded from the treatment regimen for fear of interactions with certain antiretroviral agents. Exclusion of arifamycin will likely delay sputum conversion, prolong the duration of therapy, and possibly result in a poor outcome. The next question reads, because FTR's CD4+ count is 150 cells per microliter, the decision is made to begin antiretroviral therapy after the initial 8-week intensive phase to decrease the potential for IRIS. What is IRIS? What drug interactions are likely in an HIV-infected patient receiving treatment for TB and HIV? Immune reconstitution inflammatory syndrome, or IRIS, occurs in approximately 30% of patients who begin therapy for both HIV and TB in close temporal proximity. This syndrome is thought to reflect recovery of immune responses to Mycobacterium tuberculosis and usually occurs in the first 1 to 4 weeks after initiation of antiretroviral therapy. IRIS lasts for 2 to 3 months on average, but some patients may experience IRIS symptoms for months. The immune response can be an exaggerated inflammatory response during TB therapy in a patient known to have TB infection, or it may unmask a previously undiagnosed TB infection. The risk of IRIS is greater when antiretroviral therapy is initiated within the first 2 months of TB therapy and when the CD4+ count is less than 100 cells per microliter. Symptoms include high fever, malaise, and local reactions in organs, depending on the location of the mycobacterial infection, e.g., lungs, lymph nodes, or CNS. IRIS is usually self-limiting, but supportive therapy may be required if symptoms are severe. Moderate IRIS reactions should be treated with nonsteroidal anti-inflammatory drugs without any changes to TB therapy or antiretroviral therapy. No specific treatment recommendations are available for severe IRIS, however, prednisone or methylprednisolone at doses of 1 mg per kilogram body weight and tapered for 1 to 2 weeks has been beneficial. Simultaneous treatment of TB and HIV can be complicated by drug interactions with the rifamycins and antiretroviral therapy. Rifampin is a potent inducer of cytochrome P450 isoenzymes, but rifabutin is not a potent inducer. Rifabutin is highly active against Mycobacterium tuberculosis, and data from clinical trials suggest equal efficacy with rifampin and rifabutin-based treatment regimens. Because of fewer drug interactions and documented efficacy, rifabutin is recommended in place of rifampin for the treatment of active TB in HIV-infected patients receiving certain protease inhibitors or NNRTIs. However, some antiretroviral agents may either induce or inhibit cytochrome P450 isoenzymes, depending on the specific drug, and may alter rifabutin serum concentrations. For the NNRTIs, rifampin was shown to decrease efavirenz exposures by 26%, but 2 additional studies did not show a significant effect of rifampin on efavirenz exposure. Therefore, the preferred treatment regimens are rifampin-based TB therapy with an antiretroviral therapy regimen consisting of efavirenz plus 2 nucleoside reverse transcriptase inhibitors. The efavirenz dose should be 600 mg daily. Efavirenz decreases rifabutin exposure by 38%, necessitating a dosage increase for rifabutin to 450 to 600 mg daily. For patients unable to take efavirenz due to early pregnancy or intolerance, nevirapine-based antiretroviral therapy can be used, but rifampin significantly decreases nevirapine exposures. If used concomitantly, the nevirapine dose should be 200 mg twice daily. However, rifabutin-based TB therapy may be considered with a nevirapine-based antiretroviral therapy regimen because dosage adjustments are not needed for either agent. Concomitant administration of etravirine and rilpivirine with rifampin should be avoided due to significant reduction in exposures of these NNRTIs. Rifampin should not be used in patients receiving protease inhibitor-based antiretroviral therapy, regardless of boosting with ritonavir, because rifampin causes a dramatic decrease in exposures of the protease inhibitors. Rifabutin has a negligible effect on ritonavir-boosted lopinavir or atazanavir and only moderate increases in darunavir and fosamprenavir concentrations. For patients unable to tolerate efavirenz or nevirapine, or if the HIV strain is resistant to NNRTIs, a rifabutin-based TB regimen is preferred with an ritonavir-boosted protease inhibitor regimen. However, all protease inhibitors markedly increase rifabutin concentrations. If doses of rifabutin are not adjusted, adverse drug events, such as uveitis, neutropenia, arthralgias, skin discoloration, may occur. Therefore, the rifabutin dose should be decreased to 150 mg daily when administered with protease inhibitors. HIV nucleoside and nucleotide reverse transcriptase inhibitors and the fusion inhibitor infuvitide are not metabolized by CYP isoenzymes. As a result, these agents can be administered with the rifamycins. Rifampin decreases the concentrations of the integrase inhibitors, raltegravir and elvitegravir. The raltegravir dose should be increased to 800 mg twice daily, but no dosage adjustment is recommended with rifabutin. Co-administration with elvitegravir with rifampin and rifabutin should be avoided. Mariviroc, a CCR5 antagonist, is a substrate for CYP3A and P-glycoprotein, and concomitant administration with rifampin significantly decreases exposures. The Mariviroc dose should be increased to 600 mg twice daily, but no dosage adjustment is needed with rifabutin. The next question reads, NTM is the 32-year-old partner and roommate of FTR. Because of his close contact with FTR, he is evaluated for exposure to TB by an infectious diseases specialist. NTM's HIV test is positive, and a tuberculin skin test produces an induration of 8 mm, which is positive. All other studies are negative for active TB. Should NTM receive treatment for latent TB infection? If so, what therapy should he receive? The risk of NTM developing active TB disease is significant, therefore, he should receive treatment for latent TB infection. HIV-infected persons, regardless of age, should be treated for latent TB infection. Pape and colleagues conducted a randomized, placebo-controlled trial of isoniazid therapy in HIV-infected patients. Patients receiving placebo were 6 times more likely to develop active TB than those receiving isoniazid, and patients receiving isoniazid were also less likely to develop AIDS. The preferred treatment for latent TB infection in NTM is isoniazid 300 mg daily or twice weekly for 9 months. Isoniazid does not increase the risk of hepatitis when used with efavirenz or nevirapine-based antiretroviral therapy regimens. NTM should also receive pyridoxine 25 mg daily to prevent peripheral neuropathy. Rifampin and rifabutin for 4 months are alternatives to isoniazid, but the potential for drug interactions should be considered. Weekly isoniazid plus rifapentine are not recommended for HIV-infected patients due to the potential for significant drug interactions with rifapentine and antiretroviral therapy. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 273.